خدمه الصحه بشكل افضل. النيرسينج ما بين النيرسينج او الميدوايف وبكون بده يستخدم
احد كوادر الام سي اتش عندنا، وهي اورينتد يعني حتى اكثر مني كمان خبره في هذا الموضوع، وزي ما يكون حابب تضيف ونحب نسمع.
يعطيكم العافيه. يعطيك العافيه.
ابدعت دكتوره
دوري ولا بده يشتغل؟
معنا اخر برزنتيشن لإسراء صوالحه، كلينيكال انستراكتور اند ريسيرشر في يونيفرسيتي. بدها تعطينا اليوم برزنتيشن تايتلد Unlocking Secrets Palestinian Midwives Knowledge and Attitude Toward Normal Childbirth Cross-Sectional Study. تفضلي يا إسراء.
Good evening, everyone. I know we are at the end of the day and you are exhausted and super tired, but this brings, I need your attention with me for a strict 10 minutes. Thank you, Dr. Ibtisam, Dr. Muhammad. I'm honored to be part of this conference today. They say midwives are the first hand to welcome I'm not here today just to present a study or a number on the screen. I'm here because in Palestine, we believe that the evidence is the heartbeat of midwifery care. This is a shared journey with my colleagues Tasneem Abu Naman, Amal Salamin, and under expert supervision, Dr. Sahar Hassan. We stand together to bring our attention, our care, and to enhance maternity care in Palestine. So our study title is Unlocking the Secrets. What's behind the midwife's attitudes, knowledge towards normal childbirth across sectional studies with the university. For my outline, I'm going to talk a little bit about introduction, research question, and some research questions, and objective as well, and how we conducted this study via methodology, what are our results, the conclusion, recommendation, and take-home message. Well, we know that Palestine is a coveted country to achieve the third goal of the Sustainable Development Goals, which is health and well-being. Also, to follow the strategy and guidelines and evidence-based practice to improve maternity health in Palestine. We know that the majority of Palestinian women give birth in the hospitals and receive the care from midwives and physicians, regardless of some political issues that we face. Some women may give birth in the checkpoints outside of the hospital, but majorly they receive the care from midwives and physicians. So there is still a significant gap, okay, in the evidence-based practice between the knowledge and attitudes. The optimal midwifery care relies on evidence-based practice to support physiological birth, normal physiological birth of low-risk women. Some midwives still do not implement beneficial practices and beneficial interventions during normal childbirth, and I will put underlines under low-risk women. This is very important, and we are focusing in this study on low-risk women. There is many several factors that influence midwives' knowledge and attitudes during their practice, like work overload, motivation, trust and fear, over-medicalization, the head obstruction decision also, and self-enlightenment. Well, how we conducted this study? What is the methodology? This is a cross-sectional study, quantitative design. We conducted it in 14 hospitals, contain labor and postpartum wards. Basically, we talk in our mind and focus on Nablus City because it consists of it has four private hospitals who provide maternity care and one public hospital. So the total was 3 public hospitals and 11 private hospitals from three cities, one in the south, one in the north, one in the middle, Ramallah, Hebron, and Nablus. Our sample, our population in this study were all Palestinian midwives working in labor and postpartum wards. For our eligibility criteria, midwives employed, volunteers, or internship students completed all the requirements during their study, and they are already just in the training in labor or postpartum wards. Also, the bachelor degree direct entry program, not a diplomatic, diploma entry program, and experience of 8 years or less. This is based on the last program opened in midwifery in Hebron University. For the sample size, I will highlight that we followed the enumeration technique to collect our data. So, in these hospitals, the number of midwives was 303 midwives, but the number of midwives who met our eligibility criteria were 164. The response rate was 100. We excluded all the midwives who were in a long annual leaves or maternity leaves. And the tool that we used, it's a self-reported questionnaire, consisted from 22 items. The Cronbach alpha was, as we see on the screen, 0.18. 22 statements were for knowledge, 22 statements were for attitudes. But from where we bring this tool, it's from a Turkish organ tool, consists of 29 items. We modified it, we removed 5 questions, we added another 3 questions, and we rephrased 7 questions to meet our study goal. Well, it is important and crucial for the midwives to be well knowledgeable and skilled to provide maternal health and care, and to minimize the childbirth risk on the mothers and on the babies at the same time. So our research question is, what is the level of Palestinian midwives' knowledge and attitudes toward normal childbirth of low-risk women? So our aim, we need to understand these attitudes. At the same time, we want to know the level of knowledge. For the sub-research question that I need from you, Professor here, because we are asking about what are the Palestinian midwives' attitudes regarding the avoidance of harmful practices. Harmful practices, not intervention, because intervention is something positive and we need it. We are looking upon the harmful practices. Also, what are the Palestinian midwives' attitudes regarding allowing beneficial practices during normal childbirth? For the other 2 questions, we are also asking about the level of knowledge regarding avoidance of harmful practices and regarding allowing beneficial practices during normal childbirth. Okay, now we will talk about the results. We see here a demographic data. We know that the knowledge and attitudes influenced by several factors that I mentioned before, but here I presented only the top 5 significant demographic characteristics related with the public hospital and the private hospital, I mean the hospital sectors. They were age, marital status, place of residency, number of years since graduation, and monthly salary. Let us focus a little bit on the age. Most of the midwives, the participating midwives in this study, were young age. The total of the, the percentage was approximately 50%, aged between 26 and 30 years old. Most of the midwives were married in the private hospitals, in the public hospitals, compared to single midwives in the private hospital. But most of the midwives in total were single. Most of them also were from the south. If we want to focus more and more and go into details, we can see that in private hospitals, most of them were midwives from the south of Palestine, and in the public hospitals were more in the north. Also, from the participating midwives, we can see clearly that there are newly graduated midwives from 0 to 5 years in between. About the salary, most of the Palestinian midwives in both sectors, in the private sectors and the public sectors, have an income between 3,000 to 4,000 shekels. I don't know why it's the numbers like this on the screen, but forgive me guys. Well, midwives need to continually update their knowledge. Okay? So here, in this figure, we can see midwives' knowledge scores. We have a 3 level, good knowledge, and it's equal and it flows into progression to the poor knowledge. But they are against each other. Most of the midwives showed an accepted knowledge around 70%. There is no significant relationship between the knowledge was found between, with the public and the private hospitals. We studied, as I mentioned before, around 22 states and 22 areas. But here I will highlight the highest 3 most areas in the good knowledge area: skin-to-skin contact, which putting the baby immediately after delivery on the mother belly, umbilical controlled cord retraction, allowing women to take a shower. The highest poor area where the creed maneuver, we have to highlight this and focus on this because we have to have 0% of this to help the expulsion of the baby by pushing with the fundal on the mother, oxytocin augmentation, and umbilical cord immediately cutting. On the attitudes, we have positive attitudes that align with evidence-based practices, and we have negative attitudes that against evidence-based practices. For the newborn and positive attitudes, we can see the same a little bit in the knowledge. We have here 6 areas: skin-to-skin contact, early initiation of breastfeeding. For the childbirth care, warm shower, encouraging mobility, controlled cord retraction, preventing hemorrhage, postpartum hemorrhage by giving intramuscular oxytocin. For the negative attitudes, we have the lithotomy position, we have routine amniotomy, routine administration of IV fluid, routine perineal shaving, confirming vaginal examination, 1 to 2 hours, enema augmentation of flavor. And the alarming practice, as I mentioned before, the creed maneuver was like positive attitude here. As we see, it doesn't mean it's positive and we have to do that. It means like 10% of midwives applying and performing this harmful practice. It must be 0 for this. In my conclusion, I will say that we have, regardless of the what I mentioned from negative and positive, but we still have a good 16 out of 22 areas with high knowledge among midwives and 15 out of 22 practice positive attitudes. Here are some areas we need to improve: perineal shaving, oxytocin augmentation. If indicated, we can do this, but we cannot always do this as a routine practice. Avoid routine enema, encourage oral IV fluid and light food instead of administration of IV fluid, the routine administration. Avoid lithotomy position and avoid frequent vaginal examination. For the attitude paradox, a concerning alignment with harmful practices like lithotomy position and routine episiotomy, for example, despite knowing the evidence. I call you to act. It's not only a recommendation, it's a call for action, empowering midwives and enhancing their ability to implement beneficial practices, removing the institutional barriers to ensure consistency of midwifery care. And we know that the Palestinian Ministry of Health published a protocol in 2024 for all the hospitals about labor and postpartum wards. Support enrollment in higher continuous education, decrease over-medicalization, follow clinical national protocols and guidelines. This is my message to you. Secrets have been found. Evidence is the heartbeat of safe midwifery. Do not apply non-beneficial practices. Instead, encourage and focus, enhance evidence-based practice, enhance normal physiological childbirth. Finally, I would like to acknowledge midwifery research and education development in Ghana and Palestine with Red Nora 2 program for supporting this study. Thank you for listening, and I'm super excited for this discussion.
يعطيك العافية. في عنا أي أسئلة؟ أنت تاري؟
Thank you for your presentation and your efforts. I don't speak English well like you, but I will try as much as possible.
You can speak in any language you want.
Okay. I have two questions for you. First of all, your sample size was 164, I think. Do you think is representative and generalized results for representation?
Yeah, because in Palestine, when we tried to calculate and to ask how many employed midwives, we found that we have 300 midwives employed in private hospital, in a public hospital, and 600 midwives. So, according to our eligibility criteria, according to selection of the hospital, and we are trying as much as we can just to include hospitals from 3 different cities, each one from the south, one from the north, one from the middle, and also we took all the midwives just not to miss any midwife who met the eligibility criteria, so it's representative.
So you have three governmental hospitals?
We have 3 governmental hospitals, one in Nablus City because it's the only one of the governmental hospitals that provide maternity care. We can find midwife there. Same in Hebron. In Hebron itself, not around Hebron, and in Ramallah. I will mention something like some hospitals and some private hospitals refuse to participate in the study. If we will back a little bit, we have 4 private hospitals in Nablus and 1 public, so at least we have to have 5 by 3 is 15, we have 14. So it was a little bit confusing that some hospitals refused to share in this study, and that was because many different things. I don't want to get into that.
Second question about the knowledge. You are specified good knowledge or work knowledge.
Yes.
Which skill you are used?
We use a tool. It is valid, reliable tool. Turkish one, as I mentioned. So it's a midwife evidence-based practice attitudes during labor, but not all the items was met our study goals. So we modified. I mentioned we removed 5 questions, we rephrased 7, we added another 3, and then we did a pilot study, 33 participants. We took them from another hospital, not participated from the 11 hospital we chose because we don't want to miss any participant. So yeah.
You make modification about your questionnaire.
Yeah, after we did the pilot study, we did feedback, talk feedback, and for the questions.
جزء الكويشنير كنت محددة قبل وين عملتي كمان؟ هل كلتشر أو مشابهة مجتمعنا مش معين؟
Same culture, it's in Turkish. We have the same culture. We have the same religion. We have same context. To be honest, when we just started to spread it more and more, and we just research about it. It was same in Jordan and in Egypt, but with that, we was accurate and applied it in our context. We took feedback. From the participating midwives during the pilot study. Then we continued to take this feedback and improving the questionnaire. We also did something very important. We bring a midwife. She studied midwifery and she studied English. We used her to translate. Translated from English to Arabic to English without knowing the study, without having any knowledge about the scale previously, to be accurate and to have the accurate data we want and the accurate transition and to fit our context here.
Thank you.
Another question?
Yes, to be the same track, did you do the forward and
backward translation
Yeah.
in Turkish or in English?
In English, because it was published in English.
Yes.
So, English, Arabic, and
Yes,
English.
to reconfirm this.
Yeah.
Thank you.
Okay, thank you very much for this fruitful presentation. It was very informative also, but I have a question for you because you make a call for empowering midwives. So what do you think it is the gap at Palestinian level, depending on this new research, how to improve midwife? What is the empowerment you need? This is first question. Another question that you have to be very careful, all nurses and midwives at the healthcare center, that you should know that, do you know what is the percentage of cesarean section in Palestine?
Yeah, it's around 26% in Palestine. It was higher in for 2 years, like 28, to reduce, and then it became more higher. So if you want to compare them between private and public hospital, we can see that in public hospitals it's less than in private hospital, because women go to have elective CS without any indication,
Yes.
and doctors just want to go to the hospital and get rid of
So
this woman to decrease the workload, etc.
This is an alarm that the accepted percentage of cesarean section globally is 17% for every 100 births, okay? 17. Now we are exceeding this limit. We are going to approximately 30. Okay, this is very dangerous number. Again, what is the gap in empowering midwives? What is what you say?
As a midwife, during my work, I see that self-enlightenment, and when we work, we do not follow the evidence-based practice, regardless that we know the evidence-based practice, because we don't have enough midwives working in the ward, overload, and you have maybe 4 or 5 women come to get paired in the active labor, maybe in the early labor, but you are the only midwife in the shift. And you have another patients in the postpartum ward, postpartum bleeding, high-risk cases, and you are only 2. This is one. The second one is a self-enlightenment. Like, I want to do this because I feel if I did this, I would help the woman to give birth more faster. So I want to accelerate the labor, not give the woman the good chance to have her normal physiological birth. This is very important to highlight. And let me say one important point. Physicians and doctors, the head obstetrician physicians in the postpartum ward and in labor ward make a decision to influence in midwives and use his power. So the trust and fear relationship between the midwife and the physician is one of the gaps that we need to focus on. We have a good midwives, we have to focus on them, they have good knowledge, and so we need to empower them and influence in their ability to take the decision. Midwives can take the decision by herself without going back to the physician, in some cases in low risk women. But in case if there is something high risk, you have to go back to the physician at that time. So we have this power, so we have to do this.
طبعا احنا بنلاحظ انه في عندنا عدد كبير من الابحاث هي بتركز على النولج والابحاث، وهذا يعني شيء الصراحه مش صحي للتمريض والمهن الصحيه.
Let me answer you about this part.
بنركز على النولج والاكتيف في البراكتس. هذا بدليل انه احنا على البحث اللي هو جاي من بروكلين، عشان هيك احنا بنروح نبحث في هذا الموضوع. بس هو بدليل انه احنا واقعنا ساعد بدنا نتحسن شيء.
You cannot improve any area or maternal health or nursing or midwifery without knowing the knowledge. If you know, this is the first step toward improving, knowing the level to take the second step. Yeah, this is the best. Thank you so much of all of you and for being today. Yeah, thank you so much.
ينتقل للبوستر.